Sup, guys? Welcome to the PT Good Podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
All right, Kane, we're going to be arguing the entire time about different philosophies. Now, all right, so what we're looking about today, Kane and I are going to discuss how we approach different clinical presentations. We'll talk a little bit about, touch on certain cases, but what we're going to look at is where we kind of differ slightly when it comes to evaluation, when it comes to treatment, when it comes to assessment of whether it's how someone's moving, what we think is contributing to their symptoms, and then just discussing, why we go certain routes and how we find it, how we find it fits and benefits the patient. So, Kane, you got someone coming in, your first time seeing them, you pick whatever kind of body part, condition, type of pain, whatever you want. Like, do you have a certain structure that you follow? Are you looking to assess certain things first? Take us through that.
Yeah, sure. So just generally speaking, I am almost always checking out spine first. That is usually the thing that I feel like is commonly missed. Unfortunately, it's just something that I think is starting to be taught more and more for newer grads, but previously it was definitely something that was taught more specifically to higher level clinicians, fellows, residents, etc., people who had more formal training. So I'm glad to see that that's definitely starting to change. But spine is definitely one of the first things I look at, especially if they have like different indicators that are telling me that it's going to be more spine like pathology. The second thing that I'll typically take a look at is their joint. I think that it's a lot easier to rule things in or out if we are taking a look at the joint, because it's just so much faster to respond. And also, like, if you can influence how they're moving, I think that that just makes a huge difference, typically in their symptom response as well. Lastly, I don't want to say lastly per se, but one of the later things that I'll take a look at then is going to be like maybe their quality of motion. Like, how exactly are they moving? Is it an aberrant thing? Is it something that doesn't look super pretty? Something that could be made to be a little bit more efficient, or anything along the lines of that. And then obviously if it makes a change in their symptom response. I think that covers a good chunk of it. Oh, I guess like the thing that I tag on after that would be maybe their soft tissue quality. Like, how are things feeling? If things are super tight, or if something just isn't really kicking on, if I compare it one side versus the other, or anything like that. I think that is kind of flipped interchangeably with motor control, but it just kind of depends on how the patient presents. What about you, Mark? What are some of the things that you're typically taking a look at?
Yeah, I mean, if I feel like there's a contribution coming from the spine, it's certainly the first thing I look at. Even if like we're not getting a lot of those indicators popping up, maybe I just think there could be something there. Like that's maybe they have pain that I feel like could be relating to the spine. I'll take them through a couple movements just to really tease it out. Maybe it takes just a couple minutes to do it. As long as they're on board, yeah, we're looking at that first. Obviously, if they have multiple indicators that would lead me to believe that they have spinal related pain, yeah, that's going to be the first thing. We're riding that out for a couple visits. We're seeing if that makes a change. If we're getting consistent change in symptoms that's benefiting the patient, or I'm riding that out. What I do next is, I would say I'm looking to assess from a joint standpoint, maybe not like a repeated motion standpoint, but I'm looking to take, I guess, more of like a biomechanical approach, right? So I'm looking to help things move better. If I feel like they could use, a little bit of exposure to resistance, a little bit of strengthening, things like that, we'll work that in. But yeah, that's kind of the second line there. Lastly, depending on the case, usually the first two approaches seem to cover maybe like 95% of the things I'm seeing. But if I'm really not getting anywhere with it, I'll start to implement maybe different manual techniques. Maybe it's something where the people just to generally move. Maybe it's like, conditioning type thing. Maybe it's multiple different factors contributing to it where they just need like a general exercise type program. Yeah. So thirdly, I'm looking at, like I said, maybe utilizing other things when it comes to like manual techniques, things that maybe the person can't really do on their own. And then we're using things to kind of bridge the gap. Or it's just like a general movement type thing. Maybe it's a kind of individual needs a little bit more education on movement, why they should move, benefits, things like that. But yeah, I find typically if I'm looking at, we're clearing spine. Okay. Once we go from spine, we're looking at joint, maybe contractile tissue when it comes to like maybe it's like a tendinopathy or they need a little bit of like strengthening, things like that. And then after that, we're just looking at more a general movement or utilizing other tools like manuals or specific patient education regarding movement.
So I found it really interesting as you were describing all those things when you were prioritizing certain things. You also broke it up into different classifications of how you would be treating them as well too. And I definitely think that that's a good practice for a lot of people to do, just because it helps you kind of narrow down what your differential is. So similar to what Mark was saying, if you're assessing joint, then when you're going through your testing, or you're pretty much determining, is it actually joint related? Is it tissue related?
Yeah.
So when you're going through those things, you want to make sure that you're focusing your interventions appropriately. If it's a joint issue, give interventions that focus on the joint. If it is a tissue problem, give interventions that focus on the tissue and that are related to the issue. If it's like a tissue extensibility thing, do that. If it's a loading thing, do that.
Yeah, and there's ways to tease it out, right? So like if we take, why don't we take, let's just say lateral shoulder pain, right? Referring diagnosis is a rotator cuff tendinopathy. Okay, cool. We're starting with subjective. Like we said, Kane and I were both looking at spine to start. Maybe we're talking to them. They don't have any neck pain. They never have pain when they're sitting. Posture change doesn't affect their pain. We go to objective. They have full spine movement. Their extremity movement is painful and limited, so they have some restriction there. And they don't have numbness or tingling, right? So we don't really have any indicators pointing us towards spine. Like I was saying, I might end up just having them do some repeated cervical retraction extension, a little bit of overpressure, just to see if anything changes, right? We'll get our baselines and compare. If we don't get any change there, we can kind of say for the time being, okay, there weren't any indicators looking at spine. We had them move the end range repeatedly, nothing changed. Now we can move the joint, right? So we found that they had some movement restriction, right? Let's say it wasn't due to pain, right? So we have an indicator towards something joint related, right? We could go repeated movements for the shoulder. We could see if that has any effect, and then kind of go from there, right? Let's say they had the shoulder pain, but they didn't have a range of motion restriction. That maybe points, at least from me, in my perspective, points me more towards a contractile tissue. So maybe it's, like I said, tendinopathy type thing, right? We're still going to look at spine, see if that has any effect on the painful movement. We're going to look at repeated movement for the shoulder, see if that has any effect on their baselines. And if we're not getting a lasting improved response from there, and we didn't have movement obstruction or restriction to start with, then now it kind of funnels us towards soft tissue. So yeah, like Kane said, I like building my case for these classifications, kind of funneling in, rolling things out, so I know that what I'm addressing is the right thing. Let's say if you had that case coming in, like, does your process look any differently? Like, how would you look when you say spine to the joint? Like, what does that look like?
Yeah, sure. So before I answer your question, I do want to say that the phrasing that you used was actually very useful. I think building a case, you are essentially always gathering evidence. I usually explain this to a lot of people who don't quite understand what my job is
Sure.
that you are playing detective. You need to compile enough evidence to make sure that the differential that you are coming up with holds up, and that it makes sense that why you landed on that differential, because there are a lot of times you're not going to have one clear cut diagnosis. You may have like 2 or 3 that you're working on,
which is okay,
and that's totally fine. You know, when you have more complex cases or things just aren't presenting how they typically would, it happens. And so when you are able to compile that evidence, I think that that's something that definitely goes overlooked for a lot of people. And like, they just see maybe 1 or 2 impairments and they're like, oh, it's this, I got to go with this. And that's it. Take your time, figure it out, rationalize through, and justify why you're doing what you're doing. I think that what Mark said right there, even if we differ, what he said there is exactly what I'm trying to do in all of my cases. Now, to go back to your question, when I go through and screen spine, if basically no spinal indicators like what you said, I am still almost always, it is very rare that I skip a spinal screen unless it is like an acute incident where it's just like mechanism of injury happened right now, and there's just like no other indicator for spine. Particularly if they're younger, I'm more likely to skip it then. But even for older patients, like if there's just no mechanism and I'm like, we have more pressing issues right now, we got to treat this and we got to make sure that's good. If there's something that's spinal popping out later, I'll address it at that point. But for the most part, all I do is repeated retractions. I probably will, honestly, if there's no change there, I'll probably skip patient overpressure and go right into clinician overpressure just to see, because they're usually not getting to their end range, but just to see if, hey, I'm going to bump up that force real quick. And if there's no change, we're probably good. Maybe retraction extension to see if anything changes, but I highly doubt that at that point. Because if they're having full range, everything looks good, can't really change anything regarding their comparables, I'm moving on. It's just not worth it at that point. If you miss something or something is screaming spine to you later, you can always come back. That's totally fine. But you just want to make sure, like, to me, I want to make good use of our eval time. So that's typically how I would address spine if it's not screaming spine to me from the get-go.
So then, so then you go to, let's say you're not getting any kind of change from spine. You said joints the next thing you would look at. What's that look like?
Yeah, sure. So I feel like Mark and I probably have a similar approach to this. I'm still assessing their typical range of motion. I'm going to see what their quality is, what their quantity is, and any other descriptors that fall along when they're going through their range of motion testing. Is it painful? Does it get stuck? Does it feel equal? Because sometimes it looks equal, but the patient's like, no, this feels really heavy. I may have them go through it a couple of times to see if there's like a difference after a few repetitions or anything along the lines of that. But typically just screening the joint first and making sure that, like, how does it move? After that, then I jump pretty quickly into the repeated motions testing for extremities. I just find that if it hits so fast and so well, for the most part. In particular for knees, I've had so much success with them that, like, that is the first thing I give. Like, every single time there's a knee issue. For shoulder, it's a little bit more hit or miss. And especially with the case that you're talking about here, if it is rotator cuff related, I've had some people who completely resolve, even with a tear, completely resolve with a few rounds of repeated shoulder extension, and that's it. And on the other hand, I've had people where I give them shoulder extension, they can't even move their arm back. It's too painful.
It can be pretty irritable, right? Yeah. Especially if you're thinking like maybe like small, medium sized tear, like contractile type thing. It's just like sometimes it doesn't happen.
Yeah, so I think that knowing how to use that tool judiciously and for the right patients, it definitely makes a big difference. Because the thing is, like, could if I had a patient who responded super well to repeated shoulder extension, could I have gotten them the same results doing something else? Perhaps. Could I have done it in the same amount of time and with just one exercise, and also with like not needing any other equipment or anything else? I don't think so. Like that is why I will jump to repeated motions testing so fast for extremities. Even if I jump ship faster, the fact that I at least screen it and check for it, like the cases that respond to it, it's just like
Yeah.
such a rapid response.
Yeah,
It's so
yeah.
hard to be like, no, I would never do this.
Yeah.
It just doesn't make sense.
Yeah.
It could have such a high success rate. Or let me put it this way. It's so effective for the people that it works that even if you
Yeah.
miss, it's worth taking a look at.
Yeah.
What
It's
about
like
you,
you
Mark?
said,
Do
it
you
typically, yeah, go ahead.
Oh, I was just gonna ask, do you look at extremities, repeated motions for extremities, more specifically for like certain patients? Do you do it for all patients, or what exactly is your thought process for that?
Yeah. I mean, I think it's almost, it's probably even easier to assess quickly. Like I said, usually we're seeing like more of a rapid change in extremity, even compared to spine. So it's even quicker to assess than repeated spinal movement. So yeah, if someone's coming in with shoulder, you said knee, like yeah, like knee works great, elbow. Um, yeah, I mean it's simple, right? Here, straighten your knee 10 times, push a little bit. How does it feel? Right, it's easy to measure. Same thing with shoulder. Reach back, reach up behind your back, right? Turn your palm up or pull your arm across your body 10 times. You should be able to get enough information just out of doing those movements pretty quickly. It's not happening if you're not getting that quick change. Yeah, you can begin to move on, right? But it's certainly, to me, um, yeah, it has to be part of the assessment. I mean, how should I put it? Yeah, I don't see a reason why I wouldn't test it and like every at least try it on every extremity patient I have. I'm trying to think if there's any presentations where like um where I would
You
skip
just
it, but I
won't
can't
do it.
really. Yeah, it's not like I mean we have the information when it comes to the indicators of extremity pain that you think would be coming from the spine. In the absence of like an acute trauma or like bruising and swelling and stuff like that, like, yeah, I'm going to be doing repeated movements for the extremity. So, but yeah, I mean, it's like, I mean, I think you probably feel similar. Like it's quick, it's easy to do. You'll see a quick response even just within a couple reps usually, especially if they have movement loss in the extremity. Like, yeah, I'm working into it. Like you said, someone, maybe shoulders kind of stiff, it hurts, reaching behind the back or reaching back is tight, especially compared to the other side. I move it passively and it still feels stiff and tight. Yeah, I'm going to see what happens if they keep working into it, which is different than if, let's say, they're doing it actively, reaching behind their back, it hurts. I move them passively, completely full range of motion. To me, it's less likely looking that it's joint related and that they don't have that movement obstruction that we would see that would respond to repeated movements. I'm thinking it's giving me a little bit more information pointing towards like a contractile soft tissue type thing. So yeah, I'm at least testing it. If nothing happens, more information to work with, right? If it does get better, perfect. We have a good starting point. But yeah, I kind of, yeah, it's always, I'm typically always doing it. I don't see a reason why I would skip it, especially if I'm going to get a quick lasting response. If I miss that and then I classify it as like a contractile, like a soft tissue type thing that I know is going to take a little bit longer to respond, I mean, I blew it there, right? I just wasted, 4 or 5 weeks of the person's time.
Oh, for sure.
Yeah. So I'm
Yeah.
looking at it. Do you skip it at all? I mean, now when we talk about this stuff, I mean, we're talking about acute, subacute, chronic, like not like post-op type extremity things, right? We're talking about the people coming in that have you know, general ortho type things, just to anyone who's listening. But yeah, do you see any like presentations where you're like, I'm going to skip the repeated movements on this one for extremity at least?
I mean, not off the top of my head. There are
Yeah.
certain things where I'll see and I'm like, this is not going to work, but I'm still
Mhm.
going to try it just in case. But there are definitely some patterns that you see and you're just like, nope, this is not it.
Yeah.
But
Yeah. Yeah.
to me, it's like it's still worth a try. You never know. It takes like five-ish minutes, 5 to 10 minutes
Yeah.
to rule it out. Now, I have to preface this with the fact that I am not an MDT practitioner by any means of the word. But what I will say is when it comes to screening for certain things, the fact that it's systematic, it just does the job for you. When you are screening an extremity and you check and you're like, oh, this didn't work. Well, okay, I can still go in these other directions. You checked all of them with the varying force progressions. That's it.
Hmm.
You just move on if nothing
Yeah. Yeah.
works. It just does the job for you. It takes out that component where you're like, well, did I exhaust it? Did you
Yeah.
go through every step? Yeah, then you
Yeah.
exhausted
Yeah.
it.
Yeah. If you followed it, yeah, you did. Especially too, like when you're looking at repeated movement for the extremity. I mean, it's the same thing in spine. Like you're looking for movement loss. You're looking for pain during movement. You're looking to you mainly. I mean, you're looking to see what happens when you test that joint into an end range position, right? Like I was saying before, if you you take that elbow and you get some extension, add some overpressure, really push into it, the person's fine. It's not reproducing their symptoms. That lateral elbow pain, nothing's happened to it. Nothing's happening to it. You compare it to the other side, and same amount of movement. Yeah, like all you did that once. You already have, um, I mean, you can probably repeat it, right? But if you don't have movement loss off the bat, like, and you're given that overpressure, really testing it out, it's not reproducing those symptoms. I mean, you were going to test it more, but it already gives you a good chunk of information you can work with. You feel it once, you're like, I don't, this doesn't feel stiff like that other elbow I tested out the other day that had that pain that I kept doing it and it went away, right? It just moves. It's fine. There's like, you're not doing any kind of special, glide or slide or anything onto the joint. You're just seeing what happens when try and move it on your own. So you can bundle that into your joint assessment, or before you get to your quote unquote joint assessment, you're already assessing the joint, but you're doing it in a slightly different way, right? So if you do end up having to go to more of the joint, the mobility, that kind of route, like you're building your case already. You're getting a little bit of information if the repeateds don't end up working.
For sure, for sure. All right. So we talked about how we would screen the joint, and I think that we share a lot of common ground there in that regards. Now, what do you do afterwards if you are
Yeah.
noticing that okay, this the repeated motions isn't working, having a hard time restoring their range of motion back? Maybe it's like just super cranky, you just can't really do too much about it, like it's not responding to like your normal mobility interventions. How else would you approach this?
Is this including like manuals?
um
Because usually, like, if I'm not getting a response out of like them, excuse me, doing repeated, extremity movements to assess a joint mobility type thing, um, and I think it's still joint. I don't, I'm not at the soft tissue. I don't think it's soft tissue related or contractile. I'm typically at that point, I'm like, all right, let me see what I can do and see if it helps their baselines, and then maybe they can move better afterwards.
oh,
But
so
if we're
you go to joint mobs right away?
yeah, I mean, yeah. So here's the thing: I've gone through spine. We're in the extremity. We're messing with the extremity. Like nothing's working, or it's just getting worse, right? We're not getting a better response at least. I mean, I just want to get in there and see if I can make some kind of difference, right? This is saying that we're like, we know it's joint, we know it's not contractile, it's not a soft tissue related thing. I know it's joint. Yeah, I'm like, all right. Usually at that point, we're 20, 30 minutes into the eval. We haven't really getting some information, but nothing's helping the person. I want to see what happens if I get in there, maybe a little bit, quote unquote, like a little bit more like targeted approach, right? I know this joint's stiff when I push in this direction. Yeah, I just want to see what happens. So I'm not in there long, maybe like a minute or something. I'm just doing a little bit of some oscillations, especially if they're like if that joint's getting kind of irritated. There, I don't know if they're going to tolerate more. I want to see what happens if I'm directly working into it. So
Sure.
I have my baselines. They haven't changed, or they haven't stayed better with our spine or our extremity repeateds. Yeah, for an extremity joint related thing, I'm gonna get in there and move it. And it may not even be like a when I say move it, like I'm kind of one of my professors in PT school like kind of ingrained this in us. He said, if you know the orthokinematics, you know how the joint's supposed to move and mobilize, quote unquote, mobilize anything, right? So, I'm not doing any kind of special technique. I'm just kind of using background kinesia or knowledge of orthokinematics and just kind of move the joint, right? And no kind of special hand position, just playing around with it, seeing what happens. So yeah, if I'm getting kind of stuck, I really think it's joint. Like I'm getting in there, and like let's stick with shoulder extension. Like maybe it's stiff, it's painful. Maybe what I'll do is I'll have them, they're standing typically. I'll get stabilized on the posterior shoulder with their arm by their side, elbow straight. I'll give some straight downward like distraction at the wrist, and I'll give them maybe a anterior glide PA at the shoulder with the distraction into extension. So in my mind, quote unquote, I'm making more space in the joint, and I want to see if it helps them move better. And if I get a response there, right, all I've done is I've opened up the joint a little bit to help it move better. I'm going to have them follow up with a repeated shoulder extension and see if it's better, right? So that's kind of where I go from there. That's my next line of if I'm looking to address the joint, that's where I'm going. At least at like at the initial eval, if I'm looking to make a change, looking to see if anything happens. Yeah, I'm I'm going in there with some manuals. What do you think of that?
Interesting.
Yeah, I know we've talked
That
about this
is,
before, just like casually, like about like making more space, right, and like helping the
yeah.
movement. That's where I go, man. I just yeah.
That is. I mean,
Mm-hmm.
we share very similar
Mm-hmm.
um principles,
Yeah.
but we just approach them in a different way,
Yeah, yeah.
right? So Mark jumps. I'm surprised that Mark jumps faster to joint mobs than I do.
Well,
So
it's like how should I put it? I try and make the technique specific to the movement that I feel like is going to benefit them, right? So if we stick with that shoulder example, and we know that typically if it's repeated shoulder movements, usually some form of extension is going to be what they respond to. If I'm still thinking that and we're working that direction, I want to see if they're able to tolerate it in different ways. So like I said, I'm going to try and it's it's not like your typical shoulder move, right? I'm not lying in supine, open pack position, whatever. But it's just a kind of way that I can hypothetically help the joint move better. And if I get that response and then I have them do, 5-10 reps on their own, and they're like, oh yeah, actually like, actually I can move it now and it's better. And then their baselines improve, right? We're kind of getting that snowball effect, right? So I've shown them what I can do for them and then why I can explain to them hypothetically why they're able to do that movement more. And now the ball's rolling. We're going, right? They're going to continue on their own. They understand what's going on. But yeah, not that I get in there pretty quick because it's a very small percentage of patients that actually need the like clinician techniques, the manual stuff like that. But yeah, that's where I go. I find that like as I've tried that and it's really seemed to work out well when the presentation matches.
yeah, that is. I mean, it is interesting because your approach to manuals is literally to facilitate your repeated
Yeah,
motion success.
it all comes back around. Yeah,
Which, I mean, I totally get it because I do the same thing for
yeah.
spine. I just don't do the same thing for extremities, but that
Mhm.
is definitely an interesting approach. I might have to utilize that in my own practice
Yeah,
here
I
and
really
there.
like just adding distraction to any kind of extremity move and then just doing it. Like just like I mean it's a kind of it's a very simple approach. I mean, listen, I'm not some coming up with all these crazy techniques, right? Like from a manual standpoint, I'm just like, joint stiff, joint needs to move, pull on joint and move it. Like, oh, cool. There it is. I mean, it's just like, it's a very basic biomechanical model. And I mean, I just like the distraction for the extremity joints.
Yeah, sure. I mean, I get that as well. Sometimes distraction is um definitely got me in a bad spot
Mhm.
where if I distract and it creates too much neural tension, that is definitely a no go from time to time. But
Yeah, yeah.
I largely agree with Mark's approach in regards to distraction and creating more space in the joint. Now, the biggest difference for what I noticed is that our approach is mostly to calm down the joint. And my next, I guess I shouldn't even say my next, but if they aren't responding to repeated motions, I am offloading that joint as soon as I can to get things to calm down.
Okay,
I
offload.
want to see
So like
what's up.
how are you so okay, offload. So like yeah, go ahead. And then I want to tell us how like we'll stick with our shoulder example. What's offloading the shoulder look like?
Sure, I am taking them through passive range of
Okay,
motion.
okay,
I
okay,
need
yeah,
to
yeah, yeah.
see how that thing moves without actual muscle activation. Because if it moves fine without muscle activation, that tells me so much. If it does not move fine without muscle activation, and I'm getting like muscle guarding or hard end feels or something just feels off, that also tells me something. If I can't get that thing to calm down with just gentle motions and they can't tolerate that, that is like I don't want to say it's a red flag, but that's a pretty negative indicator for me where I'm like, oh, this is either going to take some time or this is not something that I'm going to have a fun time dealing with in the next few
Yeah.
weeks. So
So,
typically when I offload it pretty much looks like that. We are doing passive range. If they can tolerate that, that's awesome. I may progress them to active range, or sorry, active assisted range of motion, like wall slides. I think are fantastic. I use them as a motor control exercise as well too. But I think that a lot of times, if they can tolerate those things, they do super, super well with it. The other way that I will look to calm down, and I am mostly looking to calm down a joint. I don't even care sometimes if it's joint or if it is contractile. I'll give them isometrics or anything like that just to see, does it change anything. And from there, once the joint is a little bit calmer, it just makes things so much easier to assess. You've pretty much just gotten rid of so much crap that is just floating around where it's just distorting your your perspective on
get in
what's
the
going
way.
on.
Yeah.
Yeah. So if you get it to calm down, their symptoms go down, you get such a clearer picture. So to me, it's just like, okay, I do my repeateds, I check passive range. Awesome. From then on, I want that joint to calm down. I don't care how I do it, but I keep that note in my head. What exactly did I do? Was it tissue related? Was it joint related? And if that's the case, if something changed, that is your indicator that you're going on the right path. Now, I'm sure Mark will probably agree with this. When we go through something like this, when we are assessing a patient, it is not a strict algorithm. It is not A, B, C, D. It usually will start, maybe A for both of us is very consistent, stays the same. B will probably differ and vary depending on the presentation, and so on and so forth. Whatever the patient is giving us, that is what we're running with. We are not necessarily like staunch
Yeah. Yeah. Yeah.
in what our process is. You have to adapt to what the presentation is telling you.
Yeah. Especially like if like on spine, or like there's no indicators for spine and they have full joint range of motion, but they just have, like I said, that outside shoulder pain. Like I'm probably not even. I've seen that their joint can move. They've showed me. They didn't have. Maybe they had a little bit of symptoms, but they have the most symptoms with resisted movement. I'm not even going to mess with joint at that point. Maybe, yeah, well, maybe we'll probably do some repeateds and stuff, but I'm not going to go manuals just because I said that was like the next thing I would go to before the contractile. All the indicators are that it's a contractile tissue issue, right? So that's where I'm going, right? But we have the kind of, the method, the systematic methodology we use to guide us, especially when, like Kane was saying, like you get like it's interesting you go isometrics. It's like, so you're really concerned about just calming things down to get a clearer picture before jumping into stuff and maybe like making it more angry.
Yeah, I mean, in my head, I'm thinking of if this patient is like fairly irritable, then like if I can't get any clear reads on where I need to go next, I really want to make sure that I calm that thing down. If they are less irritable, then I could definitely skip that for sure. I'm much more likely to give them something that is like more load based, just to see, oh, okay, if we load this area, does it get happier? Does it get crankier? And that is going to dictate the next thing that we kind of need to do. Because if it does well, awesome, controlled loading, great. Doesn't do well, maybe too much loading. Maybe that's the wrong solution here,
Yeah.
So I think that in doing so, like pretty much like what we talked about earlier on in the episode is compiling that evidence. That is pretty much what I'm doing is when I give each intervention, I'm trying to see, okay, how is it responding? And then that helps me formulate my case for what the diagnosis is going to be and how, what my next interventions are going to be as well too.
Okay, so like you've done spine, you've done extremity repeateds, you're not getting anything out of it. You would go to it, you would just see what happens as you load that area. Whereas I would go I would get into the joint more, just see what happened. Like Matt.
Well, I would offload it first. So I would, like I said, I would check passive range first, and then I would probably, if that is not responding, then I would probably go into isometrics next, just to see what it does. If it's not as irritable, load it. If it is much more irritable, then definitely use an isometric. Probably.
And then what are you looking for? Like let's say you do an isometric, you do some loading, you get like, oh yeah, it's not, it doesn't hurt as much, I can move it more. Are you within that same session reassessing extremity repeateds, joint mobility type stuff, or are you going to ride that out, see what happens, and then when you get to the next session, go from there?
So I guess this is where it can be a little bit more convoluted for people. Sure. So I will not make a return to repeated motions testing. I will probably do that on the next visit when their symptoms are a little bit more calmed down. What I will do is, if I found a way to calm it down, I'm going to go back to reassessing their comparables and their baselines. So if it's calmed down now, recheck passive range, recheck active range. Any of those things change, right? And I think that is definitely very telling. If those things change, awesome. Do another round. Does it continue to change? Even better. You're on the right track. If I only get one bout of change and then after that it plateaus, I'm probably not doing too much more. I'm probably just going to send them home with it with a conservative dose. And I usually dose my patients pretty high in regards to their HEP on eval because I want answers. But if I'm only getting one round where it's like, okay, we got an improvement, and it's not something where I'm so like, if they're super irritable and I'm like, ugh, this could be pushing it, I will probably back them off. I will probably give them less than what I normally would. Let time do its thing. Let the sheer amount of volume, because they're going to have about a week before you see them. That is a week's worth of exercise that they weren't doing previously. You're probably gonna get some change, even if I back them off, right? So that to me is going to give me a lot more answers. And if there's no change, that's okay. It probably tells me that I'm on the wrong path. and that's just using all of your available information to improve upon your decision making, and to me, like that is usually where I would default to. I actually go towards manuals and soft tissue work towards the end, actually, and I'll usually jump more to soft tissue before shoulder manuals, typically, from what I've noticed.
Okay.
I've just seen that for the most part, at least for shoulders, and I've actually started reintegrating shoulder mobs back in. And sometimes I see success, other times not so much, but what I have noticed is if I can get their range to improve, I do not need to touch their shoulder at all. I do not need to at least mob it. I don't need to do that at all. But if that isn't working and it's largely range of motion based, then I will jump to mobs a lot faster. But if it's pain based, I'm a lot less likely to jump to mobs. I'm
like
a lot
like pain
more,
without movement, like resting type pain.
No, I'd say both. Like, even
Yeah.
if it's pain with activity and stuff like that, it depends on their description. If they're like, no, it's deep, or
Yeah.
it's like in the joint, then I will take a look.
Yeah.
But if they're like, no, I feel it in like this muscle, or if it's telling me that's more soft tissue related, I'm probably not going to look at their joint quite as readily.
Yeah,
Could it be a problem? Sure.
my
But
biggest
it's not my
indicator
first go-to.
my biggest indicator is movement loss for that. They move, and it's movement loss due
Yeah.
to like, oh, I just can't move it anymore. It hurts versus, oh, like let's say let's take shoulder flexion, right? You have that lateral shoulder pain, no pain at rest. They go to move their arm and they don't have any pain until they get to the very end. Let's say they get to 150 flexion, it hurts, and go to push it, doesn't move that much farther, but it hurts more. Versus someone who has that same location of pain, but their pain starts right when they get to 90 degrees of flexion, and it continues until they get to 150, then it goes away at 180. They have full range, they don't have end range pain. To me, that's the biggest differentiator regarding if I'm going, okay, contractile or like joint related.
Yeah, sure. So for everyone who's listening, I think that what Mark is doing is great, because he's pretty much showcasing that when he decides to do an intervention or to investigate a particular movement impairment, he has justification. He has this criteria where he's like, okay, we're checking off these boxes. This is leading me towards this. I want to take a look here. Or this isn't meeting that criteria. I'm not going to look at this yet. This is going to go on the back burner for right now. Right. So having all those things, I think, is just so helpful in making your diagnosis that much more accurate, and having your evals be so much more efficient, because now you just know, okay, this meets the criteria, we go here. This doesn't meet the criteria, push it off. We'll look at other stuff. I think that is such a good way of looking at it. And I think that you phrasing it or verbalizing it in that way just is going to help a lot of people who don't currently practice in that manner.
It makes it so much more simple. Like, instead of you have this giant list of, and huge list of excuse me, huge list of conditions or diagnoses on your differential just for someone who has pain in a certain location. What if we broke it down? What if you just had them move, or you moved for them, and see what happens as you did? You just start to narrow it down so much, and it doesn't have to be we're not talking. I mean, the case was rotator cuff tendinopathy, and we're just saying that's the referral. That's what's on the referral, because the PCP, they said they had pain outside the shoulder. They think rotator cuff, right? Regardless of that, if that's accurate or not, it doesn't matter to us. All we want to see is, hey, do we think it's coming from your joint? Could it be a soft tissue related thing, or could it be coming from your spine, right? And Kane and I, not a single time this entire episode, have said like a labral tear or um, biceps tendonitis or median nerve, right? We're not we're saying soft tissue, joint, spine, right? It's like you can keep it that simple, right? And as long as you know what to look for, the kind of criteria, what the presentation looks like when it comes to addressing any of those three things, that's going to get you the success when it comes to like helping people. And I don't think like you don't have to nail down a certain structure. It's really not that important. Um, but just like knowing how to assess the different things that could be contributing to their symptoms, I think is like the true value. Is what's going to lead you to start addressing these things more efficiently.
Yeah, and I
Yeah.
I I agree with Mark. It's just like when you keep it simple like that, when you're going through your eval, I mean, I tell everyone this. I only function in ortho. I can't function in any other
Mm,
niche because of my caveman brain.
mm.
It's like thing doesn't move, I move it.
Yeah,
Thing
yeah.
is not strong,
Mm,
I make strong. And so when I take a look at all these different structures, I pretty much break it down the same way that Mark did: spine, soft tissue, joint. Afterwards, when I am synthesizing everything, maybe having to explain it to a patient, or after I've completed the eval and I need to think about it more, that's when I'm like, okay, what are the potential structures that it could be if it's relevant? Do I need to
yeah,
go
good
down that
point. Good
route?
point. Yeah. It's like how much is it
Or
going to
is it
change?
just,
Like, I mean, we're basing off like the presentation, what happens with like, yeah, I'm sure there's cases when you need to look more structurally, but then like you said, is it relevant? Does this matter? Do I need to know like, you know, is it going to change the management? I don't know. But like you said, like the relevancy is a key factor there.
yeah, I mean, how many times have you gotten a case and they're just like, well, physician told me it was this, and you're like, it doesn't really change how I'm going to treat
Yeah,
you.
yeah, I just roll with it. I'm just like,
Or
oh, okay,
what
yeah.
if you get imaging? Well, it still isn't going to change how I'm going to treat
Yeah,
you.
yeah,
So,
yeah.
like, if you already know that, then why does like majoring in the minors, why does
Mm,
that do anything? Like, it's just one of those things. You already know that answer. So why are you making it more complex
yeah.
for
It's
yourself when you don't need to?
yeah, like why do we have to introduce different variables or different points of view when as long as we have a good standardized assessment that we're looking for or breaking things down enough that you can start to identify what's contributing to the symptoms and then knowing how the patient's going to manage it on their own. Like, yeah, we don't need to know like, down to the tissue level what's happening.
Sure, sure. So, we've been on this tangent for a little bit, so I want to bring it back to a question. Now,
Yeah.
when it comes to shoulder pathology, there are a lot of papers that talk about the effectiveness of thoracic mobilization
Yeah.
or a grade 5 or manip, whatever you want to call it, and its effects on modulating shoulder pain. When do you typically take a look at T spine in regards to like a presentation like this, if ever?
Yeah, let's if you think we can definitely look at it as shoulder, but like we can even generalize this to like, what if someone has knee pain? Do we look at hip, or if they have knee pain, do we look at ankles, stuff like that? So essentially, we're saying like, are we looking at um adjacent joints or like other surrounding structures that could contribute to? Um, yeah, I mean, I'll certainly like we talked about spine related pain, but shoulder and I'm not getting a response out of cervical. Like I'm looking thoracic, right? Um, it's definitely on the table and we're looking to completely rule out spine. Excuse me. Now, when I'm looking at it from a biomechanical standpoint, which is the secondary route I'll take, if they have, keep it simple, right? If they have limited shoulder flexion, abduction, internal rotation, and their upper back's a little bit more rounded, they have pain at end range. Um, yeah, I mean, if nothing else is adding up, I can't get a response out of Peters for the shoulder. cervical spine, thoracic spine, I'm just gonna go back to basics and think, hey, maybe they just need more time working on that mobility to open up. I like in those cases, I like using like I'll have them face away from a wall, but back up to it. Try and get your head to touch the wall, upper back to touch the wall. Then we can do some like horizontal abduction. Different kind of things just to start to open up a little bit of drills to get them to use those muscles and yeah, just kind of get a little bit more extension so they can move shoulder better. Yeah, so I'll look at it from a different. I mean, it fits in all the categories we talked about. Like, look at it from a repeated movement standpoint, and then we can look at it biomechanically. And then if it's just something like I talked about, the general exercise, and we need to focus on just like getting more mobility through the T spine, we can fit into a kind of program like that too. So yeah, I look at it if it's relevant. But like I said, it's kind of we can fit it into any of those categories. Similarly to like other extremity joints, like if someone's got, let's say they have knee pain, and it's when I go down steps, and then maybe it's because they're limited in that closed chain dorsiflexion, something like that. Yeah, I'll look at it, but it's definitely lower on the list. What were you gonna say?
I was gonna ask you what was the order do you typically look at for T-spine? Does it come like with cervical? Does it come after all the other stuff that we talked about?
The one thing I look at, like if I'm looking to achieve the maximum amount of mid to lower cervical extension, it's got to be a combination of retraction with extension, right? So part of the retraction is going to be a little bit of upper thoracic extension. If they're not getting that and I see them retract and they're just running into a wall, in my mind, I'm still going to test retraction, still going to look at extension. But if those upper thoracic joints aren't moving, or they're so stiff that they're not letting them retract, or that they're so the upper cervical, oh my god, sorry, if the upper thoracic joints aren't extending enough to allow lower cervical extension to occur, in my mind, like I'm going to test it from a repeated standpoint, but if I'm not getting a result, I'm like, hey, I got to get these lower ones and move a little bit more so that we can get more information, or maybe even a clearer picture from our cervical exam. So typically, in the vast majority of cases, I'm starting cervical, but if I'm seeing like a pretty obvious restriction, and then I'm going to thoracic. But if let's just say actually probably 100% of the time I'm starting cervical, I'm not getting anywhere, I move down to thoracic. I don't typically go the opposite direction when it comes to the repeated movement exam. If I'm looking just from like a joint mobility standpoint, when in regards to shoulder movement, yeah, sometimes I'll start at thoracic, but then at that point I've already went from cervical to thoracic when I'm looking at repeated movements.
Sure. And I think I kind of fall into the same boat. Thoracic has definitely moved down more for me in the priority, but I know initially when I was first in school, they said how much effect mobilizing the T-spine has on the shoulder. And then I just kept manipulating T-spines, and I was like, oh yeah, you feel better, right? They're like, yeah, I feel better. And then they come back in, they're like, well, nothing's changed. I'm like, oh, yeah, okay.
Yeah, it's like the I forget the name of the signs. It's like this paper from like the 60s or 70s, maybe earlier, but like there's like the cervical spine can refer down to like almost like T8 or something like that. I forget. It's like pretty low, like down to like a little bit past the inferior angle of the scapula. So it's like so much thoracic and like shoulder type symptoms can have like a strong cervical component. It's like you said, like we have the papers on like the thoracic type work when it comes to shoulder movement, but it's like yeah, I mean the data is one thing, but I feel like you can get the results elsewhere, and it may not be as reproducible as like the papers we have.
Yeah, I think like the biggest thing for thoracic spine stuff, at least from what I learned in school and what I've kind of like pieced together now for myself, is when you mobilize or manip a T spine, it does a handful of things. It gives you a lot of input to help calm down some of your pain. Okay, that totally makes sense. That is going to be temporary. We all know that. That is not going to change. That's not going to make a long lasting change. Sure, can it help them within that session to get through their exercises with less pain? Absolutely. I think that is certainly one way to approach it. That is not typically how I would approach it currently, but if you want to do that, you certainly can. The second thing is when you mobilize their T spine, you're pretty much creating a better landscape for your shoulder blades to move on, right? If you can get the T spine to move better, your rib cage to move better, you are going to improve how the shoulder blade is then able to move, and that is going to impact their shoulder as well. So I think that is definitely something to consider. But to be honest with you, for people who have those issues, like especially with the, I guess, vague case that Mark and I are discussing, sometimes that's just not an issue. But for someone who's kind of stuck in that kyphotic posture and you're able to right that a little bit better, that can certainly be a patient that you work on that thoracic mobility on and get lasting results. But for other cases, for more specifically rotator cuff like issues, I haven't noticed, at least, that is something where I'm like, oh, we need to address this every time.
Yeah.
It's just, it hasn't been the case for me.
Yeah, I definitely don't go there a lot, but it's there. It's an option. If it's like really screaming at me, it's pretty obvious I go there. But I'm doing all my other stuff before that.
Sure. And that kind of ties in to the last thing that I really want to touch on, which is how often are you taking a look at their scaps? Are you looking at scap dyskinesia? Are you looking at any winging or anything along the lines of that, any asymmetries when they are going through their active range of motion? I know, for example, one of my mentors was very big on looking at scap dyskinesia and looking to prevent future shoulder issues. What is your take on looking at that, and do you incorporate that into your practice at all?
Yeah, I don't really find I ever look at it again unless it's something that's like screaming at me where it's like that inferior angle's like flying off and we got to get it addressed. Maybe I'm thinking it's like some kind of something like a I don't know, nerve palsy type
Like
thing,
a
like
nerve
something.
palsy?
Yeah, exactly. Yeah, exactly. Right, right. I don't look at it too much. Like in my opinion, I feel like that ship has sailed when it's come to like really trying to put people in the boxes when it comes to shoulder blade movement. I mean, I'm maybe maybe my view's too simplistic, but in my mind, like if they're coming with pain, any of the other interventions that I apply, I feel like I can take. I haven't much, but I don't think I've ever had a case where I'm like, oh man, like I should have worked their shoulder blade more, and that would have helped them better. I just, I don't find that I need to use that in my practice. I mean, I'm open to hearing different perspectives and maybe incorporating it, but in like my mind, from like a research standpoint and like just how that kind of stuff fits in clinically, I think that I don't know. I feel like clinically, at least from my perspective, I've kind of moved on from that. Sometimes I do, especially when it comes to like closed chain positions. Like I'll see what happens with like the shoulder blade and stuff, but um, I don't typically, unless it's like usually obvious, and I feel like it's contributing to their symptoms. Like maybe they don't have great like they get into a closed chain position and they have like right sided neck and shoulder pain, and you can see they just get like this a huge amount of upward rotation and like a little bit of like medial border like winging, and it just like it's something they could work on. Yeah, I'm not addressing it, but when it comes to like how it's moving just with normal shoulder movement, especially in the absence of symptoms, I don't look at it too much. Like if I got a referral for scapular disc and the person had no pain and they were functioning normally exactly how they wanted to, I'd just have a long conversation with them about how you know these movements are different between people, blah blah. If they develop symptoms, we can certainly address it. But yeah, I don't. I guess to summarize, I sometimes look at it, but I don't use interventions to address it. And I think it just comes from like a foundational, like what I just don't think it's I think there's variability within the shoulder blade movement. I don't think there's like a one size fit all. And unless I really think it's contributing symptomatically, I don't find it has to be addressed to resolve symptoms.
Yeah, I think the biggest takeaway from that is don't create a problem that doesn't exist. And I think that is super important. We have no idea if that is going to create problems, if it's going to fix problems, or if it's a completely net neutral and you just wasted everyone's time.
Yeah.
So that is one of those things where I'm kind of stuck on, like, if it's going to help the patient in the future, that'll be great. But the other stuff, I'm just like, we could be wasting time. We could be making you worse. I don't know if it's worth doing that, and so I think that is something that tends to be it gets lost in the mix a lot when I think that there are just so many other more relevant things that we could really be taking a look at. So when you're looking at shoulder blades, do you give Ys, Ts, Is, stuff like that? How picky are you about how they're like moving their shoulder blade, moving their motion afterwards and stuff like that? Is that something that you were really, really like harping on the entire time?
Not too much, man. Like, if I give Is, Ys, or Ts, I typically do it standing, like with the band versus like prone. Not for any like specific reason, but just because.
Interesting.
I like building the tension to end range and maintaining it. And it's typically more from like I guess when I prescribe these, it's not really a shoulder blade or scapular intervention. It's more so a end range shoulder stability. So maybe I'll start with a Y and a T separately. And then once they get good enough at maintaining that end range, maybe I'll go into I'll start with the T, that's that straight horizontal abduction, and I'll have them go into straight abduction into the Y or Y movement and maintain it. Right, so they're working on that retraction and then, sticking to the thoracic wall, and then incorporating and controlling the upward rotation with the band tension. Right, so they're just getting a ton of posterior cuff. They're getting a ton of shoulder blade work, and they're practicing that. Oh, you'll like this one. They're practicing the motor control aspect as well through the range. Versus so I like that. Yeah, right. I thought you would. I like that one a lot. But so I guess I'm not really prescribing it for the scapula. It's really just like a shoulder stability type thing, and you'll, as a byproduct, you'll get some of the shoulder blade work.
Yeah, I have a hard time believing that you're actually strengthening the scap stabilizers, if you want to call them that, with an isometric. It just doesn't make too much sense to me. I get the fact that, like, okay, you're stabilizing the scap and then you're lifting a heavier load, which requires you to be in a better position. But I think honestly, for a large majority of people doing the Is, Ys, and Ts, it's just teaching you how to move your shoulder blade. Yeah. It's teaching you how to control it, what up feels like, what down feels like, what it feels like to be in a better position, a more stable position. And that is really all you're exposing your patients to. And I think that is certainly a great place to start. I prescribe them all the time, but I will also move on from them pretty quickly if the patient demonstrates a good understanding of that. And then from there, we work on actually strengthening those muscles, which I think yields better progress because they already know how to move it. That's the big thing is once they know how to move it, it's a lot easier to strengthen.
Yeah, for sure.
All right, sir. Cool. Is there anything else that you would like to add? Any closing remarks for today's episode?
Good. I think we talked about a lot. I think we had when it comes to our assessment, like I said, spine's a huge thing, right? I think Kane and I both agree that you're, and you're gonna be doing your patients a disservice if you're not screening spine. If you miss it and it's such a quick, easy fix like that, like or if it's contributing to some degree, yeah, it should be looked at. Secondarily, like we move on the joint, we're taking a look at that. Assess it different ways, whether it's getting in there with your hands, whether it's lying the person down and moving it passively to see if you get any kind of movement restriction. Then you're monitoring any kind of pain they'd have during it too. But using that kind of assessment, yeah, it just kind of gives you a good idea of what could be contributing, right? We talked about different scenarios where, yeah, if we have a spine response, or maybe if we think it's more joint, right, we're expecting some kind of restriction in that peripheral joint, versus if they have no kind of movement restriction, they have full passive range of motion, and they only have pain with resistance. Yeah, maybe you're looking more at a soft tissue type thing. But yeah, other than that, I mean, I think we use the shoulder as a example for how we assess this. Maybe in like a future episode, we can look at like different body parts, how this kind of standardized assessment that Kay and I both use with our little nuances and differences fits in the other body parts. What do you think of that? Something you think would something we could do?
Yeah, I think
Yeah,
that would be good. I think like having our go-to interventions for specific
yeah,
things for
yeah.
different body parts could be very helpful for
Oh yeah,
people.
yeah, definitely agree. All right, anything you want to add, man?
No, I think that was a pretty fleshed out
I
episode.
liked it. I agree. All right, then. Well, that concludes today's episode of the PT Good podcast. Remember to leave us a like, subscribe to us on whatever platform you're listening to us on. Thank you for listening, everyone. We hope you enjoyed, and we will see you on the next episode.
Miss you, love you, bye.